Good afternoon, and thank you all for joining us today. I'm Dapa Wilcox, the Community Coordinator at the New Jersey Healthcare Quality Institute. The Quality Institute is a nonprofit, multi-stakeholder advocate for the safety, quality, and affordability of healthcare for everyone. The Quality Institute oversees a statewide community health initiative called Conversation of Your Life, which is also known as COIL, and it's a program of our Mayor's Wellness Campaign. COIL aims to engage communities and residents in crucial advanced care planning conversations. We discuss topics like how to communicate your wishes to your loved ones and healthcare providers, hospice and palliative care, and various advanced directive documents. Our programming is being adapted to various cultures and languages. Now, we don't know when a medical emergency or a public health crisis is going to occur. And the COVID-19 pandemic has prompted many people to consider the advanced care directives that they may have been putting off. And we want to make sure that you have all of the information and resources you need to help you make decisions about the type of care that you want. And we're going to continue to provide resources and have these crucial conversations remotely through digital resources, podcasts, and webinars like this one here today. Now, as a benefit to you and your families, we're bringing COIL resources and conversations to New Jersey workplaces, as this conversation is important to have at any age and as early as possible. And through the COIL Workplace Wellness Program, you and your family members will receive vital information on the advanced care planning options available to you and education on the different types of advanced directive documents. In addition to receiving these resources, we've implemented virtual wellness workshops tailored towards helping you ease the burden of having these often difficult conversations. Some topics you will hear about will include the various advanced directive documents, hospice and palliative care, and these tips on how to communicate your wishes to your loved ones and healthcare providers. Planning truly has many aspects, from retirement options to financial planning to living wills and the type of care you want. And we're here to make sure that you're well equipped and prepared. Now, before we begin, I wanted to touch on a couple of housekeeping items. Please know that this webinar is being recorded and a copy will be posted to our website, www.njhcqi.org, later today. All phone lines will be muted for the duration of the program to limit background noise. And you may ask questions at the end of the presentation by typing into the chat box or the Q&A tab. The topic for today's presentation is workplace wellness and the conversation of your life. Please be advised it is not the intent of this program or its speakers to provide clinical or legal advice. So today we're honored to have Dr. Vikranta Sharma, MD, Medical Director at VNA Health Group, and Jennifer Hay, Client Liaison with the Horizon Behavioral Health team, joining us for today's presentation. And after the presentation, we'll have time for an audience Q&A session. So without any further ado, I'd like to begin. And if those of you participating have any questions for our speakers, please feel free to type it into the chat box throughout the duration, and we'll get to as many as we can before the end of this webinar. So Dr. Sharma, whenever you're ready, the floor is yours.
Thank you. I'll be sharing my screen now.
Okay. Stop my share.
Are you able to see the screen, Dapa?
No, I cannot.
Just wanted to check. Gonna go in and out again, just quickly. Share screen, desktop, share. Do you want to share the slides that I sent to you, Dapa?
No problem.
So you can advance them?
No problem. One moment.
So we don't end up spending time on troubleshooting here. Okay, next slide. Today We're going to discuss the important conversation about having discussions with ourselves as well as our loved ones about advanced healthcare planning. Good morning and good noon, everybody. I just wanted to introduce myself as a palliative care physician. I also am a medical director for hospice. I work for Visiting Nurse Association Health Group, which is a nonprofit organization serving the community of New Jersey for more than 105 years now. I am stationed out of Central State Healthcare System in Freehold, which was quite severely hit with COVID-19. And we were thankfully able to deal with it in a very positive way. I'm a visiting clinical assistant professor in the Department of Family Practice and Community Health at Rutgers Robert Wood Johnson Medical School. I'm fortunate to serve as a member on the New Jersey State Steering Committee for Conversation of Your Life, which, as you all know, is the mayor's initiative for advancing public health and awareness of advanced care planning, amongst many other things. I'm also fortunate to be a member of the New Jersey State Task Force for the POLST paradigm, which is the practitioner order for life-sustaining treatment, which we are going to discuss today. And I have no financial interests to disclose. Next slide, please. So let's talk about what is advanced care planning. It is the process of communicating preferences regarding the future healthcare needs that are important to you should you be unable to speak for yourself. So it could apply to you or to your loved one. An advanced directive is a document that specifies future treatment preferences, often designating one's preferred surrogate medical decision maker. Next slide, please. Now, this surrogate caregiver will talk in the coming slides who this person can be, because that's a very crucial step and important to think about. Conversation of Your Life also has a beautiful video delineating how, in a cartoonish way, how to think about it and what are the challenges you might face. But we'll talk about that a little bit more. So a framework for thinking about goals of care is that it should be based on the specifics of the situation or the case as it pertains to this patient's disease and its treatment and the treatment side effects, should the patient choose to continue to treat themselves. Ideally, this conversation should be assisted and guided by a physician who has a long-standing relationship with the patient, who knows your social background and perhaps your process of decision-making and who you lean on and what resources you have available in your community. Treatment decisions should reflect the expressed goals of the patient and they should be congruent with the patient's known values. So known values meaning, you know, what is important to them, what disability is unacceptable, would they want to live the remaining days of their life in a nursing home situation, or would they want to be home? So, you know, where, when, how, and who of the values. It should be made in consideration with the social context and available resources. Next slide, please. So first we identify the treatment goals. They can be prolonging life, maintaining function, or comfort care only. Prolonging life focuses on care which is most likely to keep the person live longer. This may involve admission to the hospital. It may or may not involve admission to the ICU. It may or may not involve respiratory assistance in form of ventilation or cardiac compressions. So those things need to be clarified with your physician according to where you are in the disease trajectory. The second goal might be, another goal might be to maintain function. In this, the care is focused on helping the person to stay strong as long as possible so that they can do most of the stuff independently in order to maintain their dignity. And lastly, the focus might be comfort care, which a person has had a fair amount of aggressive treatment and they are bothered by the side effects of the disease treatment, or the disease treatment is really not working and they just want their symptoms to be aggressively controlled and enjoy the rest of their lives as a normal human being. So that's kind of like a holistic approach. Next slide, please. So there are 4 steps to advanced care planning: reflection on patient's priorities, communication with patient and or preferred healthcare proxy, documentation in the medical chart so it is readily visible and available to the care providers, and implementation by medical staff. Now they seem fairly simple enough, but these are all sort of passing of the baton from one unit to the other. So a lot of drops can happen in between. So if you haven't really thought things through and you just hurriedly sign a piece of paper that your lawyer has put under your nose, and not to put any less emphasis on the fact that signing that paper is important, but if it's not done in a thoughtful fashion with full awareness of what your priorities are, then it is not a meaningful document. Then you've reflected on your priorities. You need to discuss it with your healthcare proxy. And the proxy needs to understand what it is that bothers you the most about being dependent, what it is that bothers you most about being aging, being older, more dependent, or where it is that you want to be, and what sort of treatment is acceptable to you and what sort of treatment is absolutely not acceptable, if especially it turns out to be a prolonging of the suffering in addition to life itself. So further, then, once the healthcare proxy has agreed to and discussed the nuances with you, it is appropriate to document in the medical chart so that this is readily available to all participating physicians, your cardiologist, your lung doctor, etc. So this is the part where the medical system, hospitals, electronic medical record comes in. There is New Jersey Healthcare Quality Institute, as well as POLST Paradigm of New Jersey, is working on getting an electronic registry established in New Jersey, and hopefully we shall see that soon. And eventually, the medical staff need to have availability of it and implement it when the time comes when you're not able to speak for yourself. Next slide, please. Reflection on priorities. Let's focus on these questions. Who will speak for me if I'm not able to speak for myself? What sort of disability is absolutely unacceptable to me? Who is the person who will care for me when I'm physically incapable? A lot of the dignity issues kind of focus around the fact that they're incontinent, they're not able to go to the bathroom by myself. Who's going to walk me to the bathroom? More importantly, who's going to clean me? Who can I lean on? And if that person that you're choosing as a healthcare proxy is not able to make sure there's a plan for either financially hiring somebody else or talking to a palliative care or a hospice physician to understand what kind of home health aid system might be available for you. And that's one of the reasons why we recommend having palliative care involved sooner than later, because it's good to establish a good relationship, working relationship with an individual that you're comfortable with when the time comes. Again, that's not necessarily important right at the start of it, but you do have to think this through. And most importantly, what place do I want to be? If you are not looking to be in the hospital in a COVID-19 emergency where no visitors are allowed, etc., you may want to think about not being hospitalized, and that can be written on your provider order for life-sustaining treatment and even your advanced care directive. Next slide, please. So an ideal healthcare proxy has to be somebody that says their values match yours, and they don't necessarily have to be your eldest child or even your spouse. They have to agree with your decisions. If they're not agreeing with your decision, if there is conflict, you either resolve it or you need to find another person that is going to at least listen to the values that you have. So either they convince you or you convince them, but that conversation should not be avoided, because then the value of that piece of paper is just that, a piece of paper. It can be a friend, it can be a legal guardian. Especially we see that in people who are living in group homes. Next slide, please. So the decision-making unit is always a group of people, even if there is a healthcare proxy that is appointed. The patient lives in a family unit, they lean on others to find answers to their questions and make a final decision. So the patient themselves, if they're able to speak for themselves, is the first person. Then their caregivers who provide care on a day-to-day basis, then the power of attorney or the healthcare proxy. And in New Jersey, this process of decision making can be assisted and signed by physicians, advanced nurse practitioners, and physician assistants. Next slide, please. So just briefly thinking through what is going on currently, and I don't want you to take this as a snippet. It's just a small snippet of what COVID-19 looks like. It is not a comprehensive information. So let's look at it just from the viewpoint of the fact that we are trying to do advanced healthcare planning for an individual who has 2 or more chronic illnesses. They are likely elderly, anybody who has diabetes, hypertension. We know that COVID hits them more severely. Somebody who has COPD or underlying heart disease, or is in chronic renal failure, going through dialysis, etc., that they are more likely to have moderate or severe disease and end up in the hospitals. So it's important for those individuals to have the advanced care planning, much more so. But even a healthy person, you never know what the course of this disease is going to be on your body. So it is important that you fill that form out, or write your advanced directive, even if it says do everything. At least there is that voice, and at least that form will identify who's your healthcare proxy. So briefly speaking about COVID-19, there is asymptomatic carriers, of course, that is not mentioned in here. These individuals may carry the COVID-19 virus in their nasopharynx and may shed it and cause disease in a somewhat less strong or immunocompromised patient. Most individuals, 98 to 99% of the individuals who are healthy, will have a mild disease with fever, cough, shortness of breath. Other symptoms of mild disease are loss of smell and loss of taste, which generally signifies that they are likely to get over that disease without major complications. But in some cases, there is a moderate disease which involves the appearance of multilobar, meaning involving more than one lobe of the lung, pneumonia, with hypoxia, meaning the oxygen saturation is going down much below 95 in a persistent way. So as long as your oxygen saturation is 95 and above, and you are able to take Tylenol at home, drink plenty of fluids, get plenty of rest, and remain warm, and give your body a chance to heal, you might recover from the mild disease, as long as the oxygen saturation remain 95 and above persistently. If the saturations are dropping below 94 in a persistent way, you may need to go to the hospital. You might have chances of developing a moderate or a severe disease. Patients that are admitted to the hospital may develop severe hypoxia, meaning lack of oxygen requiring ventilation. So they're placed on an artificial breathing machine through an endotracheal, meaning a plastic tube placed from the mouth into the trachea, so that forced air with high oxygen concentration can be pumped into your lungs. They may develop sepsis, means overwhelming infection, inflammatory response, which means that the body is trying to compensate for the infection that is going on in the body, and it tries to withdraw the energy from the rest of the organ systems and focus on the lungs. Therefore, if some other organ systems are weaker, they might start to give in a little bit or a lot. There is enough data to now state that most of the morbidity and mortality is associated with thrombosis, meaning tiny clots form in the body. More importantly, if they happen in the lungs, they can cause pulmonary embolism, and it can result into adult respiratory distress syndrome, in which we require higher than normal pressure than an average person having a pneumonia, that can sometimes lead to pressure-related injury to the lung tissue. And also, as the oxygen and blood flow is being directed away from other organ systems, other problems can occur, like kidney injury. So if you think about it, in a person with a weak immune system, with 2 or more chronic conditions, or 3 or more chronic conditions, or advanced age, who's frail, who is dependent on most activities of daily living, meaning, bathing, dressing, toileting, feeding themselves, transferring, and ambulating, walking, then you have to understand that the prognosis, the possibility that this person will improve, depends heavily on your previous functional level. If somebody is dependent on 6 out of 6 ADLs and they have few chronic diseases, it is likely that the disease treatment is not going to work quite as well as, say, in a young, healthy 23-year-old person. So throwing the proverbial kitchen sink at that patient may not be in the best interest of some of these chronically ill individuals, and they should strongly consider, and we should strongly consider, for our relatives, if they're in that spot, to have this conversation and address this issue. The focus is on what is important to the family and the patient. Next slide, please. Identifiers for patients needing advanced care planning at facilities. So if your loved one resides in assisted living facility and nursing homes, research has shown that most people who enter nursing homes or assisted living facilities, they need assistance in most activities of daily living, meaning at least 3 out of 6 ADLs. And nursing homes are required by federal law to maintain a minimal data set of functionality on these individuals universally. So they have a good idea about what their functionality is about, discuss it with the care providers, identify that there is a declining function happening, identify with the doctor what is a major chronic illness, organ system involvement of your loved one, track hospitalization and visit frequencies in the ER, observation units, or physician offices. If you are taking them so many times to the hospital, ER, or physician office, they're certainly sicker than than an average person. Recent admission to the ICU happening is also a poor prognostic factor. Recent history of acute stroke or other events that cause neurodegenerative decline is again another negative prognostic indicator. Most individuals living in long-term healthcare institutions have diagnoses of dementia, frailty, Parkinson's disease, multiple sclerosis, amyotrophic lateral sclerosis, advanced end-stage COPD, advanced end-stage congestive heart failure, advanced liver disease, or kidney disease. It is also based on preference. Next slide, please. So the considerations for potential COVID patients in a nursing facility is that if they're not sick enough to qualify for a hospitalization, do isolation for 14 to 17 days until no symptoms for 72 hours, or there is a COVID negative test. Now we do sometimes have the ability of testing a person multiple times, but typically if once one is positive, it is probably prudent to quarantine for 14 to 70 days or 72 hours after the fever subsides. Antipyretics are the main supportive treatment, which is basically your Tylenol. Advil or naproxen can also be given. We already spoke about fluid, nutrition, rest, establishing the healthcare proxy and advance directive. If they do have a terminal condition that suggests that ICU stay would be ill-advised, please document that on the advance directive or the post. Discuss a do not hospitalize order clearly. If the goals of care imply that the comfort-focused care is desirable and accepted by the patient and family, please do document that. without much ado, and understand that do not hospitalize does not mean that they will not be treated for a UTI or pneumonia by oral medications, or will not be given oxygen, or will not be given medications like pain medications, nausea, vomiting medications. Some of these individuals are indeed better served by having familiar staff and surroundings. We know that patients with dementia have worsening delirium or confusion when they change a place, and that confusion tends to get bigger and longer and more intense every time an infection occurs. So a strict isolation may unmask delirium in these individuals, and that's not the good quality of life that most people are looking for. Patient and healthcare worker both should mask, and double masking is more helpful. Next slide, please. So in a hospitalized patient, the reason for admission is multilobar pneumonia or other chronic disease exacerbation. Usually they need higher oxygen than can be afforded at home. At home, we can only provide about 6 liters. In some facilities, we can provide 6 to 10 liters of oxygen, but the hospital, we can go up to 100% oxygen with 40 liters per minute, high flow oxygen. The decision point is if are they anticipated to land in ICU, and your physician can discuss that with you. Their physician can discuss that with you. If so, address the anticipated course in the ICU. Will a ventilator be preferable? Understand that ventilation can cause barotrauma or the pressure related changes from high PEEP, that is a pressure that is given to keep the lungs expanded. Septic shock requiring blood pressure increasing medications, thrombotic states requiring blood thinners. So if they have a propensity to bleed or have had a GI bleed, that may not necessarily be required or may be contraindicated. Acute kidney injury and the need for dialysis and ECMO. Now, dialysis is again a 4-hour job per day, 3 times a week. And if they're not strong enough to handle that, we should not be starting or subjecting them to it. Some precautions, same precautions as in facility, with the advantage that negative pressure rooms plus supportive clinical trials, etc., are still available in hospital. Proning, if the patient can cooperate, is very helpful, even in homes, even in nursing homes or assisted living facilities. It does increase the oxygen saturation by 3 to 5 points. So that's important to know, and it's something easily one can do at home. Next slide, please. What patients at the end of life wish, according to research done by Institute of Medicine, they spent a lot of time and energy in finding out what do these individuals want. And we found that we need to recognize that as death nears, most people share similar goals. They want to maximize time with family and friends in familiar places. They want to avoid unnecessary pain and suffering and make appropriate treatment plans that are beneficial. Maintain function and dignity, not be a burden on the loved ones, and try to identify clear, attainable milestones they wish to reach and support them. So that might be a graduation of a loved grandchild, the wedding, or a birthday, or just finishing reading a book, or just a walk on the beach or something like that, which can easily be provided by support services like palliative care and hospice. Offer formal contact with hospice and palliative care professionals. Sometimes primary care physicians have their own negative feelings about hospice and palliative. They don't want to be the person to discuss death and dying with you. It is okay to ask them, would a palliative care consult be beneficial in this situation? And please understand that palliative care does not mean that they are going to make your loved one DNR, DNI. They're going to discuss all options with you, understand your value systems, and make recommendations. And if you don't agree with them, we will still follow the plans that the family makes out of respect and love, and give it a trial. So I wanted to break that barrier and myth. Next slide, please, Dapa. So the tools that are available are Living Will, Advanced Care Directive, and the medical orders known as the Provider Order for Practitioner Orders for Life-Sustaining Treatment in New Jersey. Next slide. So let's quickly discuss the various kind of documents available, and what is the standard of care. The standard of care is there are legal documents and there are medical orders. Legal documents include having an advanced care directive, which can be signed by an attorney, two witnesses, and yourself, and you can say, if my doctor says I have 6 months or less to live and my quality of life is poor, I'm dependent on most activities of daily living, I can't recognize my loved ones, please don't prolong my life, keep me comfortable at home, and give me medications for pain, etc. That, approximately, that's what generally advanced care directives say. Or they may say do everything. Healthcare proxy, or the power of attorney, is a generalized term for financial, for estate, for everything, and may include healthcare proxy in it also. But the power of attorney in itself can also be just financial. So if you're doing a POA, make sure it has the healthcare proxy information in it also. A living will, we pretty much know that, sometimes it can be, how you ascribe your estate, etc. And it can also include the similar things in that document. However, these are not medically transferable order. A nurse or a doctor is not expected to, not obligated to act upon these orders. They can look at it, interpret it, talk to you or your healthcare proxy, and then make decisions. The medical orders, if you're comfortable with what you know from your doctor, have made a firm decision, this is more of in this moment, what do I want here and now? So once those orders are written, there is no confusion about your care. The team that is taking care of you looks at that and kind of moves the needle forward, as the case might be, for making sure that you are kept comfortable in the hospital. A DNR just means that we are not going to compress the chest. If the heart stops, we're not going to give epinephrine and other medications to change the rhythm. We're not going to shock you. And DNI means, do not intubate. That is pretty much self-explanatory. Next slide, please. So quickly going over the POLST form, we have a POLST paradigm in New Jersey. Next slide, please. The intended POLST paradigm population is meant to be, the POLST is a decision-making process, and the resulting medical orders are intended for patients who are considered to be at risk for a life-threatening clinical event because they have a serious life-limiting medical condition, which may include just advanced frailty. It's not necessarily meant for young, healthy individuals, but there is no harm in filling out a POLST saying that in this current pandemic only, because anything can happen to anybody and you do want your wishes documented. Next slide, please. So this is what the POLST looks like. It's a bright green form. It is, I usually tell them once this is completed that this should be placed on the refrigerator in the kitchen for the EMTs to see, so that they have a good idea about what they're going to do if somebody from the family calls 911. There's a patient's name, date of birth, goals of care. Generally, I like to put in what disease patient has and what the patient wants to do. For example, to be able to garden, or to be able to sit for 2 hours, read a book, or attend graduation, wedding, etc. The medical interventions include full treatment, limited treatment, and symptom treatment only. So full treatment basically means that if they reside in a nursing home or assisted living facility, that they're going to be transferred to the hospital. Limited treatment means that if you can treat me in the nursing home, you can do it. If I need to be transferred to the hospital, you can do that. So the threshold for that rests on the facility, what all they can provide. Symptom treatment only aligns more closely with palliative and hospice sort of a treatment, more comfort focused care. It says use aggressive comfort treatment to relieve pain and suffering by using any medications. Usually those medications are morphine in a highly concentrated liquid form that can be given under the tongue even if they can't swallow. Lorazepam, again, liquid, scopolamine patch to stop the secretions or control the secretions and gurgling, and atropine drops to do the same. Tylenol suppositories. We can also give suppositories of lorazepam if they're having seizures. We do always provide comfort, including oxygen, positioning, wound care, and manipulation of the airway. Next slide, please. Section C refers to artificially administered fluid and nutrition. Understand that always careful feeding by hand is included in this. It doesn't mean that your loved one or you are not going to be fed. It just means that an artificially placed tube is not going to be placed. That is usually a bridge to get somewhere. So it's not a long-term nutrition is not recommended ever. So that is usually not recommended in dementia patients. So then there is the section D is for CPR and airway management. Again, we can give positive pressure breathing in the absence of intubation. Usually it is only helpful if you have a mild or moderate pneumonia that we can tide over for 2 to 3 days while the antibiotic is working, and then the oxygenation improves. If it's not improving, we have to move to intubation, and therefore it's helpful to have that documented well. So section E is important that it says, if I lose my decision-making capacity, I authorize my surrogate decision maker listed below to modify or revoke the POLST order in conjunction with my treating physician in keeping with my goals, yes or no. So if you say my surrogate decision maker can change it, then check yes. If you don't want them to change it or you don't have a surrogate decision maker, you can check no, so that there is no confusion about it. Then you sign it, the physician signs it, they put their license date and their phone number, and the surrogate's information is put here. Next slide, please. These are just some of the instructions. This is not a static document. It can be changed. What I do is I put in capital letters, I put void, I sign it, and I'll say see new POLST. And that way they can see the transition of care occurring in the electronic medical record. Next slide, please. Next slide. So New Jersey POLST paradigm is in Princeton, New Jersey. Catherine Collins is our interim chief administrative officer. It is a wonderful resource for anybody who wants to know more about this green form, how to fill it out, and there are helpful slides and videos on it. Dr. Braille is our leader in this, and we're very thankful that he's taken the time to push this forward in New Jersey. Next slide, please. Who should fill out a POLST? Neither age nor admission to any facility except admission to a hospice should serve as an automatic indication for completing a POLST. Under normal circumstances, POLST is meant to be for a person with chronically ill disease that can be life-threatening at any time. Completing the POLST is for voluntary completely. Just because you're entering a nursing home doesn't mean that you should fill it out, but ideally you should. Even if a patient falls within the appropriate population and is unwilling to sign the POLST, it's okay not to do it. So it's not mandatory. It's not something that you have to do it. Next slide, please. So the difference between advanced care directive and POLST is that the POLST is a medical order and is meant to be in the moment exact orders about a seriously ill patient who wishes to fill out their treatment options. The treatment focus is current. It is completed by your healthcare provider, physician, nurse practitioner, or PA. It identifies a surrogate, and it is applicable from home to the ambulance, to the nursing home, to the assisted living facility, and to the hospital. So that is a more complete document in and all of itself. The Advanced Care Directive is a legal document, and all capacited adults should have it. The treatment focus is future. It is completed by the patient in the presence of a couple of witnesses. It appoints a surrogate, but EMS is not required to act upon it. They can show it to the doctor and say, what do I do next? But they will have to get those orders. Next slide, please. So religion and POLST. His Holiness Pope Francis gave out a message stating that he emphasized the importance of having a conversation to determine the appropriate treatments for patients near the end of life, and that there is no requirement that every means must be available to prolong their lives. So that's a big thing from the Catholic Church, and I think I have seen forward-looking rabbis and Hindu priests go in favor of the POLST because, while life is precious, it is also important not to prolong the suffering unnecessarily while we are just promoting the body. Next slide, please. So in conclusion, POLST is a dynamic conversation between patient and the healthcare provider, including discussed diagnosis, probable disease course with treatment and without treatment, knowing the expected side effects of the disease, as well as the treatment process and overall prognosis in that individuals. Once you have that information, you can figure out what disability might be acceptable to you, where you want to be, who you want to be taken care of by. Next slide, please. POLST is not a checklist. It's not just meant to do a DNR, DNI, although we do see those kind of forms being completed. We educate them that this should be filled out better, but having something is better than nothing. So, you know, I want to emphasize that it is not a checklist. It should be done with full discussions, and it can be done over a period of 1, 2, or 3 days. If you need to, you can think about it, get the information, process that information, and come back and sign it later. But please do complete it if you have you know, a chronic life-threatening illness and you're concerned about it. Next slide, please. Most important perceived barriers for filling out an advanced care directive are that the hospital-based clinicians perceive family member and patient-related factors as the most important barriers. So the doctors say the patient and family have a hard time talking about death and dying, and the patients say, you know, my doctor never talked about it. So that's one big barrier. So we all need to talk about it. All healthcare professionals were viewed as playing an important role in addressing goals of care. Everybody wants the doctors to say it. So it's okay if your doctor is shy about it to say, let's talk about this. Family members and patients have difficulty accepting a poor prognosis. Who doesn't? But we have to have contingencies, plan A, plan B, because if we don't have those plans, then end of life tends to be very chaotic, and chaos is not good. It causes anxiety and depression, not only in the patient, but also people who are left behind. Family members and patients' lack of understanding about limitations and harm of life-sustaining treatment, lack of agreement upon amongst family members about goals of care. Professional team members were reviewed as having different but important roles in goals of care discussions. More than half of the physicians reported that they feel more than half of the physicians report that they feel educationally not prepared to have these discussions. Our medical schools are doing a better job now. There is curriculum for end-of-life care. Every hospital has a mandatory 2 hours end-of-life care education every 2 years, requiring the physicians to be versed in this. So we're making strides on that. Policies that improve payment for quality should be evaluated at regular intervals to monitor their effect on advanced care planning, which is currently ongoing. Is there a next slide? This is the Dying in America report that was done in United States, this is based out of Washington. The key recommendation of this advisory council was to the Congress that we should encourage all states to develop and implement a physician order for life-sustaining treatment paradigm program in accordance with the nationally standardized core requirements. And this will go a long way in improving care in the last 2 to 3 years of life for all individuals that are seriously ill and nearing their end. Next slide, please. That's the end of my discussion. I will pass the baton on to Jennifer. Jennifer, it's all yours. You can do share screen, I guess.
Yeah, actually, we're going to keep the slides on the screen. But Dr. Sharma, thank you so much. If you wouldn't mind just putting yourself on mute, and then I think we can turn your camera off also, give you a little bit of a reprieve. Thank you for all of that really helpful information. Hello, everyone, and thank you for your interest in today's session. I'm Jennifer Hay with Horizon Behavioral Health. The information I'll be sharing with you today is an overview of how the Horizon Behavioral Health program supports you, our members. The Horizon Behavioral Health program is available to all members enrolled in a Horizon Blue Cross Blue Shield of New Jersey health plan, And that includes those offered through the New Jersey State Health Benefit Program, otherwise known as the SHBP, or the New Jersey School Employees Health Benefit Program, otherwise known as the SCHBP. We all know life can be challenging, including when we're trying to manage some of the matters that Dr. Sharma reviewed with us, whether that's for ourselves or a loved one. Statistics show that 1 in 5 adults in America experience mental illness in a given year, yet only 50% of us are getting the care that we need. We believe that your mental and emotional health are just as important as your physical health, and that's one of the many reasons why Horizon Behavioral Health offers a full range of support and services to address members' needs. Just as members need help with everything from minor injuries to lifelong chronic physical health conditions, we believe in treating the full continuum of mental and emotional health with the same attention and dedication. Whether members need help with day-to-day challenges like stress management or more significant issues that need intensive personalized counseling and treatment, Horizon Behavioral Health is here to help guide the way. Horizon Blue Cross Blue Shield of New Jersey has an expanded network of doctors, therapists, and facilities to help members get the care they need, no matter where you live or how you want to receive care. And we continually add new providers and services to meet any changing needs. Coverage includes doctor and therapy visits, in person, online, and over the phone, and digital tools that offer ways to help members take care of your emotional health and deal with stress and other more serious mental health conditions. On the next slide, you'll see there can be a lot of terms used when talking about behavioral health, mental health, or substance use disorder. Terms like depression, anxiety, bipolar disorder, eating disorders, alcoholism, and you may find yourself or someone in your family experiencing any of these symptoms. Feelings of helplessness, feeling on edge, irritability, problems with alcohol or other substances. This is just a sampling, but when you're experiencing these symptoms, it can impact any or multiple areas of your life, and it can be a sign that it's time to reach out for care and support. Horizon is here to help you find the care and resources to help you manage these symptoms. Next slide. Horizon Behavioral Health is a dedicated team of professionals who help members navigate the world of mental health and substance use disorder treatment options. Members can reach out anytime, 24 hours a day, 7 days a week, 365 days a year, to be connected to a member of the Horizon Behavioral Health Clinical Navigation Team. The team helps members figure out what is the right care for their needs at that time. The Horizon Behavioral Health team can assist with referrals to the appropriate in-network care or service for our members. Referrals can include options for telehealth, also known as teletherapy, where members can receive services while in the comfort of your own home, and increases access to in-network licensed practitioners, regular counseling sessions, and virtual therapy and coaching. Our team can also help coordinate care with your doctors and healthcare professionals and assist with discharge planning. If a situation is more complex, we have a team of clinicians who can provide case management specific to a member's behavioral health needs. And because the behavioral health clinical case management team is integrated with the physical health case management model, the behavioral health and physical health case management teams work together to support members who have both a behavioral health condition as well as a physical condition. The Horizon Behavioral Health team is also here to help members get connected to any follow-up care to maintain their treatment. The programs and services available support members' needs based on their behavioral and physical health presentation, level of acuity, and resource needs. Supplemental programs available through Horizon Behavioral Health span the continuum of care for all levels of care and severity of behavioral health conditions, with a full range of services for emotional well-being. Services like the following: individual and group therapy, crisis intervention and mental health treatment, autism care management services, online wellness and self-directed resiliency and depression digital therapy tools, virtual doctor visits, therapy and coaching, including a virtual program for those with a comorbid physical health condition, and substance use treatment programs, including medication-assisted treatment, which are evidence-based practices and peer support, where we connect members to certified peers who have walked in your shoes and can support you and your family 24/7. We know that getting the right care at the right time is important, not just in the long term, but in the short term. And since treatment is ongoing, we want to make sure that you know that we're here to help you over time, because we know that treatment is lifelong. Next slide, please. Horizon Blue Cross Blue Shield of New Jersey has an extensive network of professionals and facilities, community organizations, technology, and educational materials. Our focus is connecting you to in-network treatment providers and facilities, because we know those services and programs have been reviewed by our credentialing team. This review includes verification of a provider or facility's licensure, education, and experience. And when providers are in network, there are standards in place for the quality of care they deliver. Additionally, obtaining treatment from in-network providers means a lower cost to the member. Next slide. We understand that it can be difficult to ask for help, but you're not alone. It's never too soon to reach out for support you need. The dedicated Horizon Behavioral Health Care team will work with you, your family, and your doctors to make sure you are getting the care you need. The dedicated number for the Horizon Behavioral Health team can be found on the back of your ID card. You can also find us on the Horizon SHBP website. An even easier way to get in touch is through the Horizon Blue app, which you can download right to your phone. You can also use the app to find an in-network provider. If that all feels overwhelming or confusing, you can simply contact your Horizon Health Guide through the main number for SHBP. And if you have a behavioral health need, your Horizon Health Guide will connect you with the Horizon Behavioral Health team as needed. Thank you so much for joining today to learn about the support Horizon Behavioral Health can provide you. If you ever need our help, please reach out. Deba, I'll turn it back to you. Thank you.
So first, I would like to say thank you to Jennifer and Dr. Sharma for all of that helpful information. And before I open it up for audience questions, I just wanted to give a quick reminder that this webinar will be available on the COIL webpage so that you can review all of the information that you may have missed, and you can share it with your family members and friends. We have plenty of other resources available to you as well. We have a webinar coming up on May 10th with Prudential Retirement that will focus on the economics and the financial aspect of advanced care planning. And on our website, we have plenty of webinar recordings with various topics like support for caregivers, advanced care planning for patients with dementia and Alzheimer's, having the conversation with veterans, and many more that we didn't get to dig into the details of today, but they may be of interest to you and your families. We also encourage you to visit our website and take a look at the resources to help you and your loved ones start thinking about your wishes and strategies for how you can comfortably approach these conversations with one another and your healthcare providers. Now, I'd like to get to some of the questions that were posed by the audience. So this one's for you, Jennifer. Where can I find the mental health digital tools that you mentioned?
Sure. So the horizonblue.com/SHBP website, under health programs, there's a section specific for Horizon Behavioral Health. And then the digital tool that I mentioned is Joyable and Therapy 360. If you wanted to go online and find that yourself. Also, again, I said it before, but our team is always here to help you. If it's just easier for you to reach out, you can call the number for Horizon Behavioral Health on the back of your ID card, and our teams would be happy to connect you with those options.
Thank you. And I have one for Dr. Sharma. If you're there, if you can join us on camera. Is the PULSE form still valid if I move out of state? And how are my orders/requests?
So the simple honor is that it is honored by all states. Most states at this time have either an advancing or a mature POLST. And I quickly looked up Puerto Rico. It looks like it has an established POLST paradigm program. But if somebody goes from New Jersey to New York, say, New York has its own POLST, it's called MOLST, and it's pink in color. So if somebody comes in with a pink POLST, I will, just for legitimacy of it, I will take it and I'll fill out a green one if they're going to stay in New Jersey for that time, just so that nobody else who doesn't know that this is reasonable, if they see it, there is no problem. So we who fill out POLST are very mindful that we want to honor, that's a tool for expressing wishes. There is no exact rule to say that, the license from this is valid in this, that there has been no issues about that. So it should still be valid. Carry it, show it to your provider in Puerto Rico and say, if you have a POLST paradigm program, can you fill it exactly the same as it is? I hope that helps.
Thank you. And we have another one. Can you name your doctor as your healthcare proxy?
No, that would not be a good idea. You can name another doctor as, I mean, this is a tricky question. If my husband is a physician, can I name him? Yes, I can. But ideally, physicians have taken an oath not to be, directly responsible for the care and be the relative. That's, in our ethical, oaths that we take, is that we will not treat our family members, for example. So I think there could be a conflict in there. I would definitely run that through somebody, meaning possibly a lawyer, but I wouldn't do that. Your physician can legally become your guardian, but I would not entirely recommend just relying on the POLST for doing that.
Thank you. And Jennifer, this one is for you. I'm retired and living in North Carolina. Does the plan operate here?
Yeah, I saw that question. Thank you for calling that out here. Yeah, so if you have the benefit, you've gone through eligibility. So Horizon Behavioral Health is available to members who are actively enrolled on the health plan. And then, your location in North Carolina, the doctors that you see, would be dependent upon the actual plan that you enrolled in. But our team can help support you in identifying what's in network within your local community.
Thank you. And Dr. Sharma, can my children make a determination if I get a sudden debilitating event that I have not prepared for and my wife is not available, or will they have to go to court to get control of my medical decisions?
So sounds like your wife is your, so ideally there is a hierarchy in every state. The patient themselves, followed by their spouse, legally vetted spouse, followed by their oldest child, boy or girl, doesn't matter. And there is a hierarchy that goes down the list. So if you are making a document and want to make it, you can say, if my wife is not available, my daughter so-and-so, and if he's not available, my sister so-and-so. You can appoint that in the advanced care directive, but generally the states have a hierarchy that we follow if there is nothing there. And if there is no family member, then we have to go in for guardianship, and you definitely don't want that to happen, because that takes, in the state of New Jersey, can take about 4 weeks, and a lot of suffering can happen in that time.
Thank you. And it is 1 o'clock, so I just do want to reiterate to everyone that there will be a recording of this webinar uploaded to our site, www.njhcqi.org/resources later today. The slides will be available as well, and you will all receive an email 24 hours after the event with all the resources mentioned and the link to that webinar and the slides. And there will be
a last question about if a loved one dies of COVID-19, is there help available? So I only know of that if the cause of death is COVID-19 and there is some financial concern, that the funeral services can be paid.
Thank you. And yes, if there were any questions that you did not think of during the presentation that come to your mind later on, feel free to reach out to me at dwilcox@njhcqi.org, which is right here, and I'll be able to get you the answers to any questions that we were unable to address. So I just wanted to say thank you to Dr. Sharma and thank you to Jennifer and the Horizon Behavioral Health team for participating in today's event. And I hope that everyone has a wonderful afternoon.
Jennifer, that was fabulous information. I'm happy to see that.
Yeah, thank you.
Same to you. Thank you, everyone.
All right, take care.
Have a good one.
Bye.